This is the last part of the video series on antibiotics. And look, I totally understand that the first two parts may have been a bit overwhelming with the sheer amount of content and information in them. But look, this is a topic that will get you through a lot of the potential stations in the biomedical science examination, and really, more importantly, teach you to deal with almost the majority of infective pathologies you'll come across in clinical practice. So this video is going to go through the most common clinical infections that you're likely to see in your day-to-day practice. Talk about the likely microorganisms that are causing these infections, and give you the empirical antibiotic therapy necessary to manage these infections. So I hope this video will tie together the antibiotics topic and really cement the learning points from the last two videos. So before we start this video, I just want to spend a little bit of time talking about what exactly empirical antibiotic therapy is, because I know it's a term that's thrown around a lot. So just for the record, empirical antibiotics are the antibiotics that you can give before you get a culture result back that identifies the causative organism. They are antibiotics that cover the potential microorganisms that are capable of causing a particular infection. Once the culture results actually return, you can go from empirical antibiotic therapy to direct cover of the infecting organism. So the first infection we're going to discuss is community-acquired pneumonia. Now, you'll recognize this infection as presenting with a productive cough, fevers, shortness of breath, potentially pleuritic chest pain, and examination findings of crackles, bronchial breathing, and dullness to percussion. So community-acquired pneumonia can be caused by a number of potential organisms. And as you can see, these organisms can be your typical gram-staining organisms or your atypical non-gram staining organisms. And within the gram-staining organisms, you can see you have both gram-positive and gram-negative bacteria, and you have both rods and cocci as potential causes. So you should be able to remember this list of organisms and be quite ready to mention them when you're asked about them at your final exam. So it's a good list to get into your head. And the more you look at it, the more you'll sort of become familiar with it. It can be quite intimidating initially. So thinking ahead, you should sort of be thinking that if I am to choose an antibiotic to manage this infection, it's going to have to be an antibiotic that's pretty broad spectrum, because it's going to have to manage both gram-positive and gram-negative rods and cocci, and also have atypical coverage. Right? So some of you may already be in the back of your mind calculating and thinking about which antibiotic appropriately fits that requirement, but that's what I'll encourage you to do as we go through these infections. Right? But don't forget, particularly in children, pneumonia can often be caused by viruses, respiratory syncytial virus, parainfluenza, and also in adults you shouldn't rule out viral infections from influenza A and B. Right? That's in the community. Pneumonia can also be acquired in the hospital. Right? So and the microbes that cause pneumonia in the hospital are your typical nasty hospital-acquired bacteria, so Klebsiella, E. coli, Pseudomonas, and Staph aureus. And again, take note that you have both gram-negatives and positives and rods and cocci, right? And you should start being aware of the identity and the categorization of each of these bacteria. So when we talk about community-acquired pneumonia, one of the most important factors of your treatment is to assess its severity appropriately. And why this is important is because most of the time, community-acquired pneumonia is, as it suggests, actually encountered in the community by general practitioners, either in their practice or on home visits. And at that point, the general practitioner has to make a decision. Does this patient require hospitalization, and potential admission to an ICU for intravenous antibiotics? Or can I manage them in the community with oral antibiotics? And so that decision is quite difficult to make without criteria. But fortunately, there are criteria which are represented through scores, and the scoring systems are called SmartCorp and CORB. And there's another one used in America called CURB 65. But I would stick to SmartCorp and CORB. And these are tools to use that people in the community, health practitioners in the community, use to determine the severity of community-acquired pneumonia in adults. They assess the likelihood that the patient with community-acquired pneumonia will require hospitalization or intensive respiratory or vasopressor support in an ICU. Now, as you can imagine, when pneumonia gets particularly bad, it can require intubation with an endotracheal tube and mechanical ventilation, where a ventilator essentially forces air into the lungs to appropriately expand them. They may also become so septic, and sepsis, remember, is a distributive issue. It gives you a distributive shock in severe circumstances because of systemic vasodilation, which impairs perfusion of your distal organs. So you may need to give them therapy to constrict those vasodilated blood vessels, hence the term vasopressor. Drugs such as metaraminol, let's talk about vasopressin, and potentially drugs that also increase cardiac contractility as well as vasopressor actions, such as noradrenaline, to manage them. And these drugs, they're all never given on the ward in the hospital, they're always given in the ICU. So these tools actually help predict whether a patient will not only require admission to the hospital, but to an ICU where care can be stepped up. They also guide what antibiotics are appropriate to manage infections. And SmartCorp is preferred because it is more accurate and has been studied more extensively than CORB. But CORB is simple and doesn't require invasive testing. So if you have a patient that comes to you who looks quite ill, you don't actually need to run any blood tests on them before you can make the decision with CORB. That's why it's quite useful. And this is what CORB actually looks like. And it would be very good if you could remember this for the end of the year, when you could be asked how you would judge the severity of a pneumonia in the community. If you can rattle off the CORB score and the criteria, then I think it would be very impressive. So the C in CORB stands for acute confusion. The O stands for saturation less than 90, indicating a hypoxic respiratory failure. R is representing a respiratory rate above 30 per minute, and B is a blood pressure less than 90 millimeters of mercury, or a diastolic blood pressure less than 60 millimeters of mercury. Now, if you have one of these, if you have none of them, you're probably a mild pneumonia. If you have one, you're a moderate pneumonia, moderately severe that is. And if you have two or more, then you are a severe pneumonia, and that indicates that you probably need an ICU admission. But anything over mild requires hospitalization. Okay? And like I said, depending on what category you fall into, the antibiotics that you'll need will vary as well. So if you remember the causative organisms, there were gram-positive cocci, gram-negative rods. They were also atypical bugs. So for mild patients that need oral antibiotics and that don't need hospitalization, you can either give amoxicillin or doxycycline. Now, the big thing, amoxicillin is obviously a good broad-spectrum penicillin, but it doesn't cover your atypical organisms. And the reason it doesn't do that, if you remember, the penicillins are cell wall inhibitors. The atypical organisms don't really have a cell wall to inhibit. Whereas the tetracyclines, like doxycycline, they're good broad-spectrum antibiotics with very good coverage of the atypicals. So they tick both boxes. They're broad-spectrum, and they cover the atypicals. And if you remember why that is, they're actually protein synthesis inhibitors. They act on the 30S ribosomal subunit to inhibit the bacteria producing proteins, and they're bacteriostatic in that way. But the reason why you probably don't give doxycycline as much is because its side effect profile is a bit bigger than amoxicillin, so it's slightly worse tolerated. But it does have better coverage, so just be aware of that. Now, if you're getting to hospital, what you want to be giving the patient is IV benzoyl penicillin. Now remember, that's the first generation penicillin. It has very good activity against strep, so strep pneumonia will be managed well with it. And you add oral doxycycline to the IV benzoyl penicillin because it'll give you coverage against everything else. Make sense? In severe disease, and these patients, like I said, they probably have to go to ICU, they probably have impending organ failure, and their CORB has to be 2 or more. What you give is a broad spectrum and third generation cephalosporin, ceftriaxone. Remember, they cover almost against everything except the lame organisms. That was the mnemonic I introduced in the last one. And you give them azithromycin. So the lame organisms, again, Listeria, MRSA, Enterococci, and of course the atypical organisms they don't cover well against. And you give them with azithromycin, which is good against gram-positive cocci, and the atypicals. So together you cover for everything with these 2 antibiotics. I hope that makes sense. You have to remember these antibiotics, but it makes it a lot easier to remember them when you have an understanding of how they work and which organisms they work with. The combinations do make sense that way. So let's move on to meningitis. And meningitis, obviously, you can probably pick it up from a person who may have severe headaches, photophobia, neck stiffness, running high fevers, and the causative organisms for meningitis vary depending on the age of the patient presenting to you in practice. So if it's a newborn, a neonate, you have to be really wary of organisms that might have infected the baby while it was being delivered through the vagina. So group B streptococcus, remember gram-positive cocci, E. coli, so that's a native commensal organism of the gastrointestinal tract, and Listeria, which can also be transmitted by the mother before birth and cause meningitis in the newborn. In children, actually, viruses are often the biggest cause. So viral meningitis is a very common entity. So the Coxsackie viruses, mumps, and polio now is so rare it's almost eradicated. But then you have to be considering the bacterial infections, so strep pneumonia, Haemophilus influenza, and Neisseria meningitidis. And in adults, Neisseria meningitidis is the most common cause, but the the organisms are the same, they're just flipped around, strep pneumonia, Haemophilus influenza. And looking at these bacterial causes, remember, there's a gram-positive cocci, and a gram-negative cocci, and a gram-negative rod. So again, you're looking at something that's probably going to be broad spectrum, and that also has good penetration of the central nervous system to be an effective antibiotic. And again, some of you may already be knowing which antibiotic that's calling for. In immunocompromised patients, you should be thinking a little bit more laterally, thinking about potential fungal infections, thinking about Listeria, thinking about herpes simplex virus. And again, in hospitalized patients, thinking about the nasty Pseudomonas staph aureus. But the empirical management of meningitis actually involves, if you can, and suspect meningitis, giving a course of oral steroids. And that simply reduces the inflammation and reduces the pressure in the cranial cavity and buys you some more time. But the oral steroids must be started before or with the first antibiotic. If they're started after the first antibiotic's given, I'll give you an example. If the general practitioner sees this patient in the community and gives them a dose of antibiotic, there is no point giving them the oral steroid once they're in hospital because there's no proven benefit to that. And the antibiotic that's used is a third generation cephalosporin. Again, we were calling for a broad spectrum antibiotic that had good penetration of the CNS, and the cephalosporins do that. Now remember again, the lame organisms they do not cover against, and listeria is potentially a cause in immunocompromised patients. The atypicals don't normally happen. MRSA doesn't really happen for meningitis unless it's hospital acquired, and enterococci doesn't generally happen. So if you think this patient might be immunocompromised and you want to cover for listeria, you simply add benzyl penicillin to cover for that. And you may want to add vancomycin, not for MRSA in this case, but to cover for strep pneumonia if gram-positive diplococci are seen or there is a concurrent otitis media or sinusitis. Let me just go through how that normally happens in clinical practice. So normally to see your causative organism, the investigation you need to do with meningitis is to do a lumbar puncture, right? The lumbar puncture comes out and you can do a microscopy straight away of the lumbar puncture with a gram stain to look for any organisms that might be present in the sample you've just picked out of the lumbar puncture. Now, this is before you send it out for your full culture, which will take a couple of days to come back. So before that, you're just looking under microscopy. If in that microscopy you see gram-positive diplococci, which are suggestive of strep pneumonia, that is when you give vancomycin. And why you give vancomycin rather than keeping them on ceftriaxone or giving them a more targeted benzyl penicillin is that strep pneumonia in these cases is becoming increasingly resistant to penicillin. So this change to vancomycin ensures adequate empirical therapy in an infection we're particularly worried about. I hope that makes sense. And again, we'll move on to the next infection. So, infective endocarditis. So, this is an infection of the endocardium which is the inner lining of the heart, and quite often presents with fevers, the new onset of a cardiac murmur, and also the peripheral stigmata, which you've probably heard about before, the Janeway lesions, the Osler nodes, the splinter hemorrhages. And the main causative organisms are actually the viridans group of strep, which are the commensal flora of the mouth and gastrointestinal tract. And remember, these are all gram-positive cocci. You can have the commensal organisms of the skin, particularly in injecting drug users, so these are also gram-positive cocci. You can have enterococci, and you can, in the minority of cases, you have gram-negative bacilli. And this group of gram-negative bacilli is called the Hatchik group because that actually spells out it's a mnemonic for the organisms. So the Hatchik organisms are actually responsible for the very small number of cases of infective endocarditis, but it is something you should mention, and it is something that your antibiotics will cover against. So your antibiotics cover against the gram-positive cocci and the gram-negative bacilli. And so if you have your own heart valve, you haven't had a prosthetic heart valve transplant, then the antibiotics you cover with are intravenous gentamicin for the gram-negative rods, benzyl penicillin for the strep species, and strep species and enterococci species, and flucloxacillin for the staph species. And why flucloxacillin rather than vancomycin, you might be asking? It's because flucloxacillin is more effective than vancomycin for methicillin-sensitive Staph aureus. But if you suspect MRSA, you can replace the benzyl penicillin with vancomycin, right? If you have a prosthetic valve, however, you can go straight to gentamicin, flucloxacillin, vancomycin. So the last infection we're going to talk about are the urinary tract infections. And urinary tract infections are typically broken up into cystitis and pyelonephritis. And cystitis is typically an infection limited to the lower urinary tract. So literally it means inflammation of the bladder. And it typically presents with urinary dysfunction, so increased frequency and urgency, and maybe a bit of suprapubic tenderness and low-grade fevers. And most of the time in women is actually asymptomatic. Pyelonephritis is much more serious because the infection has ascended all the way to the kidneys. It can present with fevers, chills, rigors. It can present with costovertebral tenderness and features of sepsis. So when you suspect a urinary tract infection, you have to be kind of aware of where you think that infection has reached. And the causative organisms are a lot of the commensal organisms of the gastrointestinal tract. And the mnemonic here is KEEPS. So that includes Klebsiella, E. coli, Enterococci, Proteus mirabilis, Pseudomonas, and Staph saprophyticus. That's the mnemonic, but in terms of most common to least common, E. coli is by far the most common. Staph saprophyticus is very common in females of reproductive age, and then you get the rest of them. Now again, you've got a mix of gram-negative rods and gram-positive cocci, so you're thinking you're going to need a broad-spectrum antibiotic. So in terms of empirically managing patients where you believe there's a cystitis, if they're a non-pregnant woman or a man, you can give them your choice of one of 4 broad-spectrum antibiotics. Trimethoprim, the dihydrofolate reductase inhibitor, cefalexin, the first-generation cephalosporin, amoxicillin, with clavulonate, the broad-spectrum penicillin, or nitrofurantoin. Now, nitrofurantoin, I didn't actually mention it in the past 2 lectures, and that's because it's this weird bacteria that doesn't really fit into any groups, but it's shown to have good activity against all the organisms that tend to cause urinary tract infections. It's the only place where this drug will ever come up. You'll never be asked about its mechanism of action because I'm not sure it's fully known. So don't worry about that too much, but just be aware it's one of the empirical managements for a cystitis. In pregnant women, you're not allowed to give trimethoprim, and that's because, remember, it's a dihydrofolate reductase inhibitor. And folic acid synthesis, that's one of the enzymes we also use, and it's obviously very important for the maturation of a fetus, right? So you actually give folic acid supplements to ensure neural tube closure. Second line, if there's resistance, use the quinolones, so norfloxacillin, ciprofloxacin. You can use those drugs as well as second line if there's no effect with your first line agents. If you have an acute pyelonephritis, now, as I mentioned, this is much more serious. Pyelonephritis can lead to scarring of the kidney, chronic kidney disease, and you need to get on top of it quite quickly because these patients can get septic, they can go into shock, and they can really deteriorate fast. So if they're mild, you can actually start them with oral antibiotics. And it's essentially the same treatment as cystitis, but you can't use nitrofurantoin in this case. So you can use the trimethoprim, the cefalexin, or the amoxicillin. If it's a severe infection, they're looking properly septic, tachycardia, tachypnea, low blood pressure perhaps, very febrile, then you have to treat them as a gram-negative sepsis. So you treat them with gentamicin IV, that covers all the gram-negative organisms, and then you can use amoxicillin or ampicillin. So they are broad-spectrum they obviously cover the gram-positive as well. So that will give you complete coverage in these patients.